In this five-minute med audio on antihypertensive drugs, I'm going to briefly review about different classes of medications that are helpful for lowering high blood pressure. High blood pressure is, according to standard guidelines, is any blood pressure above systolic 140 and diastolic 90 millimeters mercury. So just quickly to review what blood pressure is, it is cardiac output combined with systemic vascular resistance. That is the amount of pressure the blood vessels have to exert in order for the heart to pump out blood. That's the cardiac output. So if you multiply the heart rate into the systemic vascular resistance number, that's the blood pressure. Diastolic is the contractibility. Systolic is the pressure when the blood is filling the heart. Compared to what is pushing from the vessels. So that's the brief basis. And if you remember from the previous cardiac part 1 drugs, we talked about vasodilators as potent vasodilating mechanisms of opening up the arterial smooth muscles to decrease blood pressure at the same time to help with angina. So if you look in this table towards the end, there is vasodilators. Do remember that vasodilators are usually used only in hypertensive emergencies for hypertension. Otherwise, they're used for angina. So examples of vasodilators are hydralazine, that's sodium nitroprusside nitro products. With that aside, the next few things, the drugs classes that we will discuss are the A, B, Cs. So the way I like to classify hypertensive drugs are by the alpha-1 blockers, the alpha-2 blockers, ACE inhibitors, angiotensin 2 receptor blockers, ARBs. So we call them the ACEs and the ARBs. Okay, so if you look at the classes, so there is 1, 2, 3, 4 ACE, alpha-1 blockers, alpha-2 blockers, ACE inhibitors, and angiotensin 2 blockers are the ARBs. And then you also have beta-1 blockers, that's the B, and then C is calcium channel blocker, so ABCs. So if you think of the alpha-1 blockers, they act in the alpha receptors of the blood vessels, that's the arterial walls, and thereby they help in treating hypertension. So if you look at alpha-1 blockers, examples are tamsulosin and terazosin. So the ones that are ending with the sins, those are alpha-1 blockers. They're also given to relieve BPH symptoms, that is benign prostate hypertrophy. Some of the side effects include for this class of drugs are constipation. And anytime when patients are placed on these hypertensive, we watch for low blood pressure and sometimes orthostatic hypertension as well. So patients can have dry mouth, they can have bradycardia as well. With this group of drugs. And in general, like beta blockers too, beta-1 blockers can cause, bradycardia. So you watch the heart rate and blood pressure before you're giving those medications. So then bringing to the next class of alpha, that is from the A class of meds, that's the alpha-2 blocker, clonidine, which is centrally acting. So it means it crosses the blood-brain barrier. It also enters the central nervous system. It works by decreasing the norepinephrine production. So sympathetic response, right? Decreasing that activity, thereby reducing the blood pressure. So this is usually given with caution. It's also given for opioid withdrawal symptoms. And so that's another use of this medication, clonidine alpha-2 blocker. So the next category of A drugs are ACE inhibitors. If you remember the RAAS system from your pathophysiology, the renin-angiotensin system, you need to understand the system before you know those drugs. So those, the A's are the angiotensin converting enzyme inhibitors. So these inhibitors, or these drugs, inhibit the enzyme ACE that's secreted by the lungs, thereby decreasing blood pressure, because angiotensin 1 is converted to 2, which is a proton vasoconstrictor. So if you inhibit angiotensin, this conversion by an enzyme, that's how this acts, you can reduce the blood pressure. And this is usually the first line of drug for CHF. But one potent side effect is that some patients, there's this persistent cough. In some patients, there could be as severe as angioedema, which is an anaphylactic reaction. So in that case, even epinephrine doesn't work. Giving like for the bee sting, right? When patients receive, epi in their give themselves an epi shot, right? It doesn't work for this type of angioedema, which is a severe anaphylactic reaction. The other things to watch for is hyperkalemia. So look at the blood levels of potassium in the non-productive cough that patients have. Some people get better with long-term use, but for some it doesn't. It doesn't help much. So they might have to be changed to an ARB then. So however, one good thing about this medication is that they're renal protective. So meaning if patients have any type of renal problem, they're safe to be on this drug. So as you know, hypertension can affect the eyes, the kidneys. So it's important to be watching for those functions because of vasoconstriction, right? High blood pressure. So the next class of A drugs are the angiotensin II receptor blockers. Those are the ARBs, and those end with the name sartans, losartan, valsartan. And they act again on the RAAS system by inhibiting the angiotensin II receptors, or blocking, I should say. Sorry, not inhibiting, blocking the angiotensin II receptors that release aldosterone. So aldosterone, as you'll remember, it keeps the potassium and let goes of the sodium and water, right? Those are the blockers. So for these patients, they're given for hypertension and heart failure as well. Some not severe side effects, but these people can also sometimes have the cough, but not all of them. But headache and upper respiratory infections are common. Again, if you think of the RAS system, because the lungs are involved in this directly or indirectly, there are some side effects related to the lungs. The next group of medications are beta-1 blockers, which we reviewed in the previous slides, in the med table. So the OLALs, right, the atenolol, metoprolol, propranolol, those are all beta blockers in general, but beta-1 blockers are very specific, targeting only the beta receptors of the heart. So something to watch for in them would be bradycardia and hypotension, to know when to hold the medication for these patients. If the heart rate is below 60 and if the blood pressure systolic is below 100. So usually there is a protocol written in the setting that you work. So that's the B class of drugs. And then the next class of drugs and the last class are the calcium channel blockers. Again, these calcium channel blockers can be given for angina, as we talked in the other med table. And also they can be used for smooth muscle relaxation and hypertension. So one potential side effect would be dysrhythmias. So watch in patients who have any type of like bradycardia or other types of arrhythmias. And then monitor blood pressure for them too. Again, watch for constipation. So in general, lifestyle is very important even before we place them on these drugs. So increasing physical activity, following a DASH diet, that's a low salt diet, and then watching, portion control in food. You probably heard of Choose My Plate, right? So those type of interventions can help before patients are placed on these drugs. But one of the important things to know for hypertension is that the risk for stroke is very high for patients with high blood pressure, and damage to the kidneys, causing chronic renal failure is the next thing. Again, then cardiac issues too. Thank you.